All right, everyone. We're going to be now starting chapter 20, the drugs that affect blood clotting. So we're going to go through that right now. All right, so definitely read up on the clot formation, thrombosis, and embolisms that are in the beginning of the book. So read up on that just to realize about clot formation. You do need to know lab values, which are on page 325. On the top there, especially the INR, that's most important. What we want to worry about is especially if they are on warfarin or Coumadin, that INR is the one that we've been always talking about. A normal INR is from 2 to 3. So anything that's usually going to get above 3, we start worrying about, and then that's when we start worrying that the levels are too high. They may have to hold the Coumadin. So those are what we want to. Now the APTT, the activated partial thromboplastin time, that is going to be more for heparin, especially we watch that very closely when we are doing heparin drips and giving heparin. So we want to monitor that. But the most important one right there is the INR. And like I said, when in normal range is 0.8 to 1.2, but when we're using it to prevent clot formation in people who have had heart attacks, strokes, and etc., then we want them in the therapeutic range of 2 to 3. Sometimes the doctors want those therapeutic ranges higher, just depending on what has happened with the patient. Like mechanical hearts and things, they may want it even higher. So that just depends on each case. But like I said, 2 to 3 is therapeutic. Anything higher than 3 is considered to be too high. And then we start having to decrease doses or hold the dose for a day and check levels the next day. So we're going to be going over that stuff. So you definitely need to know at least that the INR and know that the APTT, that's going to be checking for heparin. And the INR is checking for Coumadin. So you do need to know the difference between the two. All right, so let's do some basic stuff. Now we know with anticoagulation drugs, they do not thin the blood. Now we do call them blood thinners because it's easier to tell the patient it thins the blood, but actually it does not thin the blood. They do not dissolve clots already formed, okay? So anticoagulant drugs will not bust up clots, but they do prevent new clots forming, and they keep clots already there from getting any bigger. So that is the thing of it. It's going to prevent new clots from forming, and it is going to keep the clots that already exist from getting bigger than what they are. So that is the big thing with our anticoagulant drugs. We use these drugs to prevent clots forming after heart valve replacement. It will decrease risk for strokes or heart attacks. They will prevent venous thromboembolisms, which they call VTE, but we normally know it as DVT, deep vein thrombosis. And usually everybody still calls it DVT, not the VTE. They're used during open heart surgeries to prevent clots for patients on bed rest. We always give them medication if they're in the hospital. We will always give them prophylactic heparin just to prevent them from getting clot formation because they're not moving around. And then we also use them for dysrhythmias, especially when we talked about dysrhythmias, atrial fibrillation, because the heart isn't squeezing. So what happens is the blood just backs up into those chambers. It's just sloshing around. And when blood isn't moving or circulating, what does it do? It starts to clot. And so that's what we use it for, to prevent those clots from forming. Okay, so that's anticoagulant drugs. Now, when we're talking about thrombolytic drugs, now thrombolytic drugs will actually dissolve clots already formed. All right, we give these meds to people who are having heart attacks, are actually having strokes, pulmonary embolisms, clots in the lungs, or other clot-related problems. These are the ones that will actually dissolve and bust the clots. Okay, so anticoagulant drugs do not bust clots. They just prevent clots from getting bigger and forming clots, and thrombolytics will actually bust the clot up and dissolve it. So those are the two different types of things we're going to be talking about in this chapter also. So things we do before we give any type of drugs that affect blood clotting, we make sure we have a list of all medications, especially over-the-counters and herbal supplements, because a lot of them affect bleeding, especially aspirin. If they're taking aspirin, anything that contains aspirin products, ginkgo biloba, St. John's wort. Those are things that are going to cause issues with blood clotting. Another thing important to do is make sure we get a set of vitals. And the most important ones, heart rate and blood pressure. but get a full set of vitals. But heart rate and blood pressure are the ones we're concerned about. And of course, before we would give any of these medications, we would want to make sure that we did lab work. We'd want to check the coagulation studies to see where the patient is normally at. And that also will help with what amounts of medications are going to be prescribed. Get a list of all allergies, not just meds, and of course, antidotes. We want to make sure we have antidotes for some of the clotting issues. You want to make sure that the med is available, okay? And that's very important. So usually the hospitals do have the antidotes, especially our facility has the antidotes for a lot of these medications. In case we have to give it to them if they're bleeding out, we can give them the meds quickly to reverse the effects of the meds. And we'll be talking about that in this chapter also. Childbearing years, we're going to ask about pregnancy if they're pregnant now, or if they future are going to become pregnant, if they're breastfeeding, or if they had a miscarriage or an abortion within the past 24 hours. Because these drugs can cause severe bleeding and patients can hemorrhage. So that's why it's very important to know that stuff beforehand. We also want to know if they have a history of any bleeding problems. We want to look for any bruising, if they've noticed any big time bruising on their bodies. Maybe just recently they've had bruising on the legs or the arms. That's something to report before we give these medications. And do they inject self with needles? If they inject themselves with needles, they may know when they're on these medications that they may have bleeding at the site. So that's sometimes not uncommon. So what do we do after we give these meds to affect clotting? Well, we want to always monitor for signs of bleeding or allergic reactions. That's very important. Everyone taking these medications will be at risk for hemorrhage, especially after we give these drugs. So everyone we need to be watching for, and we very important to make sure we teach our patients to look for it also. So we need to do that. And also teach the signs of bleeding. People complain of abdominal pain. They can have some swelling in the abdomen, back pain, bloody urine, bloody stools, those black and tarry stools. If no one's ever seen black and tarry stools, once you see it, you will know it. Also, patients will complain of constipation because if they're bleeding, the body's going to take all the water. That's why they become constipated, because they're trying to prevent the body from shutting down. So that's the body's response. It will take all the fluid it can and save it in the system. If they're coughing up blood, if they're complaining of dizziness, headache, joint pain, and if they have that coffee ground emesis, that's just digested blood, we need to report that immediately. They need to call their doctor, or go into the emergency room to be checked. Like I said, very important to monitor the blood pressure and heart rate and pulse ox frequently. Especially when we first start these medications, we want to make sure we watch it. And if we get a blood pressure, if it decreases, it can be signs of bleeding. And we're looking for, remember our parameter, less than 90/60 millimeters of mercury. That is our parameter. Also, a sign that they could be bleeding is increased heart rate, greater than 100 beats per minute. And also decrease in the pulse ox of 3 to 5% lower than normal baseline. So that's why it's important to get those vitals beforehand. Always hold pressure when you give IMs, intramuscular shots, or IV sites. If you're removing an IV site, you're going to have to probably hold pressure for at least 5 minutes. Sometimes it may be longer. You'd be amazed how many times when we take out an IV and we hold pressure for a little bit, then all of a sudden we tape it up, we didn't see any bleeding, and then all of a sudden the patient comes out and dripping blood everywhere. That is not uncommon. So that's why it's important to know before we take out IVs or do IMs, what are they on any type of anticoagulating drugs and what we have to do for it, because they will bleed. That's why we have to hold pressure. We're going to teach our patients that they need to get frequent lab work. They need to get their labs checked, their coagulation studies. Take the med at the same time. If you miss a dose, you should take as soon as possible, but do not double the dose because it can cause big time bleeding. And that is one thing we do not want. We do not want our patients to bleed. Teach them about the side effects and to know the signs of bleeding, like bleeding from gums, when they're brushing their teeth, cut or wounds that ooze blood, or they're bruising easily, more bruising, like they just someone touches them and they bleed, start bruising. Nosebleeds that are very hard to control. Those are things that we need to monitor and report. And then we have to watch for the more serious bleeding. Those are the ones that are going to be pale around the mouth and nail beds, very, very rapid heartbeats, increased respirations. They're just lightheaded, dizzy, they could even pass out, and they're very thirsty. So those are some things that is when we get into bad side effects and adverse effects for serious bleeding. We should always inform the dentist if we're on these meds before getting dental work, and we should report these meds before any procedure or surgery. That's very important. We should avoid contact sports of anything that can cause injury, internal bleeding. So running, jogging, jumping, and high impact exercise can cause bleeding in the kidneys as well as in the joints. So it's not recommended for anything that's going to be, if you're going to have to do a lot of hitting, like contact sports, if you're doing a lot of running or jumping, those are not recommended because you can actually cause bleeding in the kidneys, and you also can bleed into your joints. So that's why they do not recommend those. You can walk, slow, nothing to impact that we want. And also they recommend that medical alert bracelet. We've talked about that many times. They do recommend having that on. So we're going to talk about the types of drugs that affect blood clotting now. Now, we're going to talk about the anticoagulant drugs, okay? Remember, we don't use on patients who are at risk for bleeding, okay? Because if we give it to them, they're going to bleed. So that's why we have to be very cautious with these. We don't give to anyone with bleeding ulcers because it's going to make those ulcers bleed. And we do not give to anyone who has had surgery or delivered a baby within 24 hours because they can hemorrhage. So there are 3 categories of these anticoagulating drugs that we're going to talk about. We're going to talk about the direct and indirect thrombin inhibitors. That would be heparin. We're going to talk about, the second one would be clotting factor synthesis inhibitors, which we're going to be talking about our warfarin and Coumadin. And then we're going to talk about our antiplatelet drugs, which is aspirin. So those are some categories we're going to be talking about coming up here. So we're first going to talk about the thrombin inhibitors, and the direct and indirect just depends on how it affects in the system, with the clotting system and all that. Okay, so when we're talking about the thrombin inhibitors, and I think that starts after but like I said, go through all the stuff about clotting. Thrombin inhibitors start on page 328. All right. Now, thrombin inhibitors, like I said, they can work in the blood clots directly or indirectly. And like I said, the most on page 329 is going to be our common thrombin inhibitors. So for the indirect one, the biggest one we have here is heparin. And we do give a lot of sub-Q heparin. We also give IV heparin, just depending on the situation. When we give IV heparin, the first dose is usually weight-based. And then it is calculated according to the lab values afterwards. So we will weight-based it, and then afterwards it will depend on the lab, and then we will adjust the rate depending on that. Now, when we're talking about low molecular weight heparins, the biggest one that we use on there is enoxaparin or Lovenox. So at the hospital setting, what we're giving is we do give sub-Q heparin. We are allowed to do that. You will not give IV, but you can do sub-Q. And you will be giving a lot of the low molecular weight heparin, and that's enoxaparin or Lovenox. So that's the big one on there. So that's the indirect. So it indirectly works on the thrombus. Now, the direct thrombin inhibitors, these are a lot of the pills that we take. Some of them are IVs, but these are the ones that we give a lot of. Now, we do give apixaban or Eliquis. We do give that. Let me see. I'll try to find dabigatran, which is Pradaxa. We do give a lot of that. And we also give rivaroxaban, which is Xarelto. So those are the 3 biggest ones that we do give out right now in the settings, and there are actually antidotes for those in case we need to, as well as heparin and these medications. So we're going to be talking about those, and we'll get into that. All right. So Like I said, we do give IV heparin. We need to obtain an activated partial thromboplastin time. So we need to obtain an APTT before we start heparin, because that is the lab work for specifically for heparin, APTT. And we will do that before we give it. Like I said, heparin is weight-based, and then we check it by the APTT. We do give a bolus, and then we will start a continuous drip of this med that will get adjusted depending on the level. We keep the patient in a therapeutic range to prevent clot formation. So we usually want that level 1.5 to 2.5 times greater than their pre-lab work. And we can get it as high as 3.5, so just depending. We give sub-Q heparin to prevent clots and emboli, especially to patients in hospital settings, usually ordered every 8 hours. So we will give those sub-Q injections, and that is to prevent them from getting any clots while they're not moving too much while they're in bed. Now, the low molecular weight heparins, and that, like I said, like the enoxaparin, we do give them sub-Q. They are also to prevent DVTs and pulmonary embolism. So sometimes people go home with these medications. Usually we'll give to post-surgical knees, hips, and abdominal surgeries. Anybody who's at risk for developing clots, that is what they're going to be giving these low molecular weight heparins. The nice thing is that the low molecular weight heparins don't need the lab work drawn to maintain their dose like heparin does. So that is the sweet part about it. Now, if a patient has heparin, you have to get that APTT. But if you're on the low molecular weight enoxaparin or Lovenox, you do not have to get lab work. We do still monitor like the platelets and things like that to make sure things are, okay with labs, but they do not have to come in if they take it home. They do not have to come in to get lab work to maintain the dose. So that's a good thing. That's a positive thing about the low molecular weight heparin, especially enoxaparin. So the direct thrombin inhibitors, we do give IV to prevent the clot formation or embolic complications. Usually we give when person has an allergy to heparin. So we will give those ones. Oral doses are for long-term use to prevent clots in people with AFib or other clotting problems. So usually the IV is like if it's first initial and we're starting it, and then usually they'll maybe get them on sub-Q and also start them on some pills, and then they'll end up taking pills for the rest of their time. Side effects. And those are going to be on page 329. Side effects, risk for bleeding. Okay, all things we mentioned about bleeding issues before, that is going to be in this. Remember, very important to remember that females will have heavy menstrual bleeding. It's going to happen. We are making the coagulating taking longer to clot, so people are going to bleed more. Dizziness can occur. Okay. Long-term use, they can actually have increased potassium level. So remember, important to know your potassium level. Can cause osteoporosis. Platelet levels will decrease, so thrombocytopenia. Decreased aldosterone levels. Blood clots in the spinal cord and hair loss. Alopecia. So there's a lot of things that can occur with the side risk of taking these medications. Now, the adverse effects, of course, there's allergic reactions. That's why it's important to know everything. So they can have breathing problems, chest pain. They can get the angioedema, the swelling to the face. They can get hives. They can get very itchy. Also, another adverse is that necrosis of the tissue, especially when we give sub-Q heparin in the abdomen. Usually it's seen at the site of infection, or not infection, injection. And these people need to go to surgery to remove that tissue. It is rare, but it can happen. So there can be necrosis of the tissue when we give this sub-Q heparin. So that's why it's very important to make sure we do things appropriately, inject things appropriately, make sure that we do a sub-Q, not an IM. So that's why it's important to make sure we do things appropriately. So before we give these meds, what the heck are we going to do? We're going to make sure that we have some antidotes, okay? So Protamine sulfate, this is the antidote for heparin, and that is on page 329 in that drug alert, action intervention alert. The antidote for heparin is protamine sulfate, okay? We want to make sure that we have that available if we're giving heparin. Now, also, we want to make sure if you have Praxbind, Praxbind, that is the name brand. Now, the generic is IDARUCIZUMAB. This is the antidote for dabigatran or Pradaxa. Okay, so Praxbind or IDARUCIZUMAB, that is the antidote for Pradaxa. And you want to make sure you have that available. Now, Andexxa, which is ANDEXXA, that is the name brand. The generic is coagulation factor XA recombinant and activated ZHZO. Okay, that is the generic. That's pretty long. So it's that coagulation factor XA recombinant inactivated ZHZO. This is actually the antidote for rivaroxaban, which is Xarelto, or apixaban, which is Eliquis. Those will cover those two medications. So if they're having bleeding issues and we need to prevent the bleeding issues and we need to get them a little, I'll say it, thicker, even though that's not it, to coagulate faster, we will give these as the antidotes. So make sure you know those, because those will definitely be on a test, okay? So those are the antidotes you need to know for this so far. Now, our low molecular weight heparins, we do need to give them deep sub-Q injections. The best thing is to make sure the patient is lying down. We do not remove the air bubble in the syringe. Okay, the air bubble needs to stay up. We hit it up to the plunger side. We squeeze the fat because it is a sub-Q. We want to make sure we're squeezing that fat. We inject the medication without aspirating because we know if we aspirate, that's going to cause tissue damage, and we don't want that. And we're going to monitor, make sure once we give it, we do not make sure the patient, once we inject it, we take out the needle, then release the fat. And we want to make sure that the patient does not rub the site or that we rub the site, because if we rub the site or they do, it will cause bruising. So we want to make sure we monitor that that is not being done. Afterwards, we want to make sure we, after we give these meds, IV heparin, we're going to monitor the IV site very closely. We're going to be monitoring for that lab value, the APTT results, and we'll adjust the medication appropriately. We're going to teach our patients, don't take any aspirin or anything containing aspirin while on these medications unless okay by a physician, okay? We do not want them to take ibuprofen or any NSAIDs unless okay by the doctor, because this will actually increase bleeding. Remember, our NSAIDs can actually increase bleeding. That's why we always held them up to 48 hours before surgery, because of the bleeding issues that it can cause. So we do not want to make sure that we do not give anything, any aspirin or aspirin-containing products, ibuprofen, any NSAIDs, because we do not want the increase in bleeding, especially if they're getting IV heparin. So if they're having any pain and they wanted something over the counter, probably the drug of choice would be acetaminophen or Tylenol, as long as it's not contraindicated if they have any liver issues or they're alcoholics. Now, our pregnant and breastfeeding population, guess what? Heparin is the drug of choice for pregnancy and breastfeeding because it does not pass in the milk. It can cause bleeding in your last trimester and during pregnancy. I mean, not pregnancy, but during delivery, it will actually cause a lot of bleeding. But if a mom gets a pulmonary embolism, the heparin will be the drug of choice that they're going to put her on. But the nice thing is it does not affect the fetus and it will not pass in the breast milk. So that's a positive thing. So the only thing, I'm going to say again, heparin. They can use heparin if they have any blood clotting issues. Now, our older population, they are more likely to see these side effects. They're the ones that we're going to see more issues. Think about their skin as it is. It's paper thin. They just bump it and they bleed and bruise. So we're going to be really watching them. So a lot of times, They're going to be on lower doses. We're going to be watching their injection sites. You'd be amazed sometimes that you inject a patient, then all of a sudden the entire area around there's bruising and you can see the bleeding underneath the skin. So you do have to watch that very closely. So very important, sometimes they will apply ice or some cold compresses to the injection site, but a lot of blood clotting tests, they need to come in and get checked frequently. So those are indirect and direct thrombin drugs. Now the second one we're going to talk about is the clotting factor synthesis inhibitors. And these are on page 331 in the book, okay? And it's warfarin or Coumadin. So that is clotting factor synthesis inhibitors. So it's inhibiting the clotting factor. And like I said, this is a big one we give a lot of, and that is warfarin or Coumadin. It is to prevent the formation of clots and emboli. Sometimes it's not impossible to be taking heparin as well as warfarin and Coumadin for a few days until the INR is in desired therapeutic range. Then they will actually discontinue the heparin, okay? So perhaps the patient has started on heparin, and the doctor says, well, patient can go home. But what we need to do is start them on their Coumadin to make sure that we get their INR levels to a perfect amount. So once the INR is in a therapeutic range or where they want it, they will actually start weaning off the heparin and they will just be left with the Coumadin or warfarin. So that's what we usually do. So remember, APTT lab for heparin, INR for warfarin or Coumadin. So make sure we know those things. So know that our INR, the normal is 0.8 to 1.2, therapeutic is 2 to 3. And like I said, sometimes even up to 4 to 5, that's depending on why on the drug. Like I said, sometimes mechanical hearts, they'll do a little higher or some others, it depends. But usually you'll see it 2 to 3. Going up to 4.5, those are for special occurrences. So side effects for these drugs, again, and that's on page 331, bleeding, blood in the urine or stool, okay, headache, upset stomach and diarrhea, fever and skin rash. Okay, those are the major side effects, but bleeding is of course going to be the biggest one, and a lot of those side effects can be caused due to bleeding, like blood in the urine and stool, headache, and when you're bleeding you can get a headache, upset stomach, diarrhea. So those are some things that we have to watch for. Now adverse effects, hemorrhage, unusual bleeding or bruising, those black tarry stools, blood in the urine, I mean blood clots in the urine or just all blood in the urine. They're very fatigued. They can have a fever, chills, and a sore throat, because that would be like an infection going on. Tummy pain, headache. They say it's the worst headache in their life. And we have to be very cautious when they say that they have the worst headache in their life when they're on these medications, because if they pop a blood vessel, they could be stroking out. They could have a hemorrhagic stroke, so we have to watch that. So that's when they say, so when they're on these meds, we always take it seriously when they say they have a headache. Vomiting blood, that coffee ground emesis, or even bright blood. I've seen it where people are pouring blood out. So those are some things that we have to watch for. We also have to watch for the skin necrosis again. It is rare, but it is more seen in the women who are obese and going through menopause. Excuse me. It happens with large doses, especially if they're on large doses of warfarin, and it is seen 1 to 10 days after starting the drug. Usually the treatment with high doses of vitamin K, they will give IM or IV to reverse that, because remember, vitamin K is the antidote for warfarin or Coumadin. So that is what the antidote is. So you will see that as an adverse effect. So hemorrhage, abnormal bleeding, that headache, that's really bad, as well as the skin necrosis. It can happen, it's rare, but it can happen. But it's usually in the obese menopausal woman. Now, like I said, vitamin K is the antidote for warfarin. The common brand of the antidote is phytonadione, which is aquamaphyton. So that would be PHYTONEADIEON, and then that is the generic name. The brand name, aquamaphyton. AQUAMEPHYTON. Sometimes you'll see it just say vitamin K. So before we give these meds, we want to make sure we obtain the INR before we give it. So we want to know where they are at, where the range is at the moment. We also want to make sure that we have vitamin K available in case we have to give them a quick dose of medication. We're going to make sure we watch if the patient is eating a lot of green leafy vegetables because it contains vitamin K and it will decrease warfarin's action, and we do not want that. We do not want to give if pregnant or going to become pregnant. We want to watch our herbal supplements because it can interfere with these drugs. Afterwards, we want to repeat the INR test on a regular basis, and we want to make sure that we tell them to avoid large amounts of vitamin K. So do not hit the salad bar and eat all the green leafy veggies. We want to make sure that they stay at a normal, good rate. What we want to teach the patients is maintain their diet on and don't alter it because it can change the INR results. If they did eat a lot of green leafy veggies, broccoli, cauliflower, and that, or anything with high vitamin K, to report that because their levels, they may have to have their levels checked. And alcohol. Alcohol interferes with the action of warfarin, so it's not recommended to drink. Don't take any products with aspirin unless okay by the doctor. After stopping your warfarin, it takes several days for the body to go back to normal clotting ability. And the only way of checking that is by doing an INR and making sure that it's in normal range. Now, the pediatric population, it's rare to be on the med. We would not give any IM shots, IM shots, no aspirin products, and no contact sports at all because they will have bleeding. Pregnant population, we never, ever, ever give warfarin. We need to use birth control while on these medication so they do not get pregnant because it will cause big time birth defects and bleeding to the unborn baby. The only medication we can give, remember, is heparin. So warfarin is not the drug of choice for pregnancy. It will cause a lot of bleeding and birth defects. Now, our older population, lower doses, a lot of side effects like bleeding and bruising. We need to monitor the INR more frequently. So that is the second category. Now, the third one is our antiplatelet drugs. These are used to prevent clots in the brain and cardiovascular system. We use it for coronary artery disease, heart attack, strokes, people who have TIAs, and peripheral vascular disease. On page 332 and 333 are our common meds that we use them. Aspirin. Aspirin is a big one. Let me see, clopidogrel or Plavix. We will give tons of clopidogrel. Let me see. I can't see with the thing. We do use the ticagrelor or Brilinta. We do use a little bit of that. I'm seeing more using that with a lot of our people who go to the cardiac cath lab because they're having a myocardial infarct or heart attack. We've been doing the Brilinta more than anything else. We used to give clopidogrel a lot, but our physicians now are using Brilinta. So we'll see how that goes. I don't know if there's some new study or not, nothing that has come across me, but any of those things are anti-platelet drugs that we can use, but aspirin is a big one. Now, aspirin, which we can say is our salicylic acid, with aspirin, the big thing with that is we can do aspirin levels, and we can also monitor if a patient overdoses, we will do a salicylic acid level to make sure that they haven't overdosed on aspirin. But aspirin will be the most commonly caused. When we have someone who's complaining of a heart attack, remember I said MONA is what we're saying. If they're having an active heart attack, we want to make sure we give them morphine, oxygen, nitroglycerin, and the A is for aspirin. So that's why when patients come in, we always ask them, did you take an aspirin before you came into the hospital? Because that is going to be the most important thing. We want them to take an aspirin for any signs and symptoms of heart attacks. So those are the common ones that we use. The side effects are going to be also on that page, 333. Side effects will be bleeding, headache, dizziness, and it can cause GI upset, nausea. If it causes the upset, nausea, they can eat with the food. Adverse effects, though, it's going to be hemorrhage and allergic reactions. The big thing with aspirin, if they do have salicylate toxicity, they will have tinnitus. So a lot of times we know if they're taking too much aspirin is they will complain of tinnitus, which is ringing of the ears. So then we will do that level, the salicylate toxicity level, to make sure that everything is down. And of course, it can cause a low platelet count, thrombocytopenia, so we do need to monitor for that. So what are we going to do before we give these meds? Well, antacids will interfere with the absorption of the antiplatelet drugs. So we're going to give these drugs 1 hour before or 2 hours after giving antacids because it will interfere. If it upsets your stomach, causes nausea, we're going to give it with the meal to decrease those things. Afterwards, we're going to take these, we're going to make sure we teach the patients, take them with food if the gastro problems, we're going to repeat that. And they may have to be on these meds for the rest of their lives to prevent the clot formation and keep clots down if they do have clots. Do not stop these drugs unless unless the doctor tells them otherwise. And of course, the pregnant and breastfeeding population, the last 2 weeks of pregnancy, it can cause big time bleeding problems for the baby, and it does pass in the breast milk, so breastfeeding is not recommended. So the recommendation of choice would be what, of course? Heparin. Heparin is the drug of choice for the pregnant population. So that is the first part of the chapter. I'm going to come back and I'll do the second part of the chapter here in a few. So I will be back and we will discuss more.